Welcome to this talk on biliary tract ultrasound for the WAX ultrasound learning module. I'm Casey Parker. There is an instructional video in the Teams folder which you can follow the link below, which is about a 6.5 minute video that goes through the practicalities of how to go about actually finding and examining the gallbladder and biliary tree on ultrasound. So I won't spend too much time on it on this talk, but it's all available on the folder. The summary of that talk is that if you're going to be scanning people's gallbladders, fasting really does help. As you fast, your gallbladder fills with bile, it gets bigger and becomes more visible. Try to use the liver as your acoustic window, so wherever possible have some liver in the foreground of your field, which avoids bowel gas, and asking the patient to take a nice big deep breath in and hold it can bring the liver down and create a nice acoustic window through which you can see the gallbladder easily. We always like to move our patients when doing biliary tract ultrasound. One, because it makes it easier to see. If the patient is rolled into the left lateral decubitus position, it is much easier to see the gallbladder usually, and particularly the porta hepatis region. And also because we can then see if the contents of the gallbladder are mobile, so if stones that move around with gravity are more likely to be asymptomatic or non-sinister stones. The other approach that is often useful is to look in between the ribs, so bring the probe out laterally onto the lower part of the thorax, angle the probe so it's in between the ribs, and you can often get a good picture of the gallbladder and long axis with that particular approach. It's also a very good approach for looking at the portal vein, which runs straight towards the probe in that orientation. Typically, the portal vein is easy to see. It's very consistent in most people. It runs up through the pancreatic head, up into the porta hepatis, and that's the region we're looking at. It's a large, dark, anechoic blood-filled structure, and you can usually spot it. And if you can follow the portal vein up to where it meets the gallbladder neck, that's the porta hepatis, and that's where you really want to be looking for culprit stones. It can also allow you to get good pictures of the CBD. So the portal vein is a good landmark to be able to identify and follow. Now, the neck of the gallbladder is the most important part of the gallbladder. This is where we really want to make sure we get a good look at what's going on, because patients with stones that are stuck in the neck of the gallbladder are the ones that we really need to act upon quickly. So in order to get a good look at the gallbladder neck, you may need to roll the patient, look through the ribs, and follow that portal vein to make sure you're getting right up towards the neck. Remember that stones do shadow, so using shadowing is a clue to where stones may be. Sometimes it's hard to see, but if you can see a shadow, then you know that there must be something blocking the beam and there must be a stone nearby. So here's the basic biliary tract protocol that we'll be using. We try and get a nice long axis, ideally with the fundus through the body down into the neck of the gallbladder, and ideally you should be able to see the porta hepatis as you can on this top left image here, where you can see the common bile duct just coming into the screen there. So that's a great picture in long. And then in short, we like to take pictures of the gallbladder at the fundus in the body, and then once again down at the neck. The short axis is where we like to measure the transverse diameter of the gallbladder, because it's much more accurate than measuring it in long, and anything over 4 centimeters is probably abnormal. And we like to measure the gallbladder wall thickness. Usually we measure it in the long axis, and usually we measure it where it's up against the hepatic parenchyma, so anterior wall of the gallbladder typically, where it's close to the probe, and you may find it easier to zoom up to get a nice big blown up picture to make that accurate measurement. And last of all, we do like to get pictures of the porta hepatis. If you can identify the common bile duct as it tracks anteriorly along the front of the portal vein, that's usually the easiest way to see it. Sometimes you can see it in the pancreatic head, but if you can identify the common bile duct and measure it from inner wall to inner wall, it should be under 6 millimeters. Now, obviously, if we do see pathology such as stones, we like to look at where they are. We like to roll the patient to see if they're mobile stones or if they remain lodged where they are. And probably one of the most useful things we can do as point of care clinicians is do a sonographic Murphy sign. And to do this, you need to bounce the probe over the actual fundus when you've got the fundus in the center of the view, and then also bounce the probe in an adjacent structure such as the stomach or the antrum, just to see if you can elucidate where the maximal point of pain is. So true Murphy's positive is when the maximal pain is over the fundus of the gallbladder. Now go through a few normal variants here. So the top left of screen, This is a clearly normal gallbladder. You can see it in nice long axis, and you can see the neck diving away down towards the porta hepatis, and that is a nice view. You'd sweep through that in 2 planes to make sure, yes, it is indeed normal, but that looks like a nice, normal, healthy looking gallbladder. Top right of screen, we have a gallbladder that contains a stone in the fundus of the gallbladder. You can see the stone is nice and bright, hyperechoic with a shadow behind it, and that is a classical gallstone. However, that stone's probably not causing that particular patient many problems in that position. It may intermittently be obstructing the gallbladder, but not where it is at the moment. And so we'd want to roll the patient, make sure it's mobile, but stones are so common in middle-aged people that could just be a normal, innocent gallstone. The third picture there in the bottom left of screen shows a small contracted gallbladder, and this is the typical appearance of a postprandial gallbladder. So if someone's just had a meal, as is often the case in the emergency department, it can be very difficult to actually identify the gallbladder, but this is what it looks like. It's a small structure in the same position up against the right free edge of the liver usually, and it's often small and contracted, and the wall does look thick, but it's symmetrically round, and we get the clue that this is just a normal contracted gallbladder. We just ask the patient, when did you last eat? Now, gallbladders can come in all different orientations and folding arrangements, and the common one that we see is a thing called a pharyngean cap, which is essentially where the fundal part of the gallbladder is folded over on itself, so you get this little bend in the fundal end, and this is a normal variant, though it can look like an internal abnormality to the uninitiated, so just look at it in a couple of different planes and try and build up a mental picture of what it looks like, but that's a pharyngean cap right there. Alright, I'll just play this video. This is a classic video, and what we're seeing here on this clip is a couple of areas of shadowing. It's really hard to identify the gallbladder, and this is often the case when the gallbladder is completely full of stones. So here at the start of the clip, we've got this dirty gas shadowing. This is from bile, could be transverse colon or duodenum, we don't really know, which is giving us this dirty gas shadow and obscuring everything over here on the right side of the view. But as we play through the clip, come through to here, you can see this is more hard solid shadowing. So there's these hyperechoic gallstones with hard solid shadowing behind it. So this is what we call the wall echo shadow sign. So when you see a gallbladder that's completely full of stones, it can be really hard to see because it doesn't have that nice black appearance. Here's the wall as the green line, there's a thin rim of bile, and then there's this hyperechoic bunch of stones which are packing the gallbladder completely full and making it impossible to see anything deep to it. So be aware of that, and just be aware that sometimes people don't have gallbladders, and you can spend a bit of time looking for it and then ask the patient, have you had yours removed? Because that's the other trap for young players. A couple of other things can make it really difficult to work out what's going on. We've mentioned the wall echo shadow sign here on the top right of screen. So this is a gallbladder that's once again completely full of stones, and you can just see that thin dark rim of bile, and then the bright hyperechoic stones beyond that with a nice dense dark shadow. So that's a true gallbladder full of stones, wall echo shadow. You can get a thing called a porcelain gallbladder where there's calcification in the actual wall of the gallbladder, and that can look very similar. It can be hard to differentiate, it's much rarer. Usually shows up nicely on an x-ray. So yes, if you've ever seen those x-rays from the old days, that's a porcelain gallbladder. That is a disease that's reasonably common called diffuse adenomyomatosis, which is we get these little cholesterol pop deposits building up in the crypts in the wall of the gallbladder. These can be patchy, or you can have a whole wall full of them, and they give this bright white echogenic ring down artifact, which can be quite confusing. It looks like there's something in the gallbladder, but it's just an artifact arising from those cholesterol crystals. And so be aware that that's not uncommon, usually seen on the anterior wall against the liver or up at the fundus. And lastly, if you have gas in the gallbladder, gas can produce shadowing once as well, but it's usually not such a hard black shadowing, it's more of a dirty grey shadowing. And the trick is that it's usually arising from the most antidependent, so the bit closest to the ceiling, as opposed to gallstones, which usually fall to the bottom of the gallbladder and usually at the bit closest to the floor. And I'll just give you a couple of examples here. Here's an example of a fan through a longitudinal view of gallbladder. I'm just going to stop the video there. So what we can see here is we can see some stones up here in the fundus of the gallbladder. We can see this sort of isoechoic fluffy, sludgy looking stuff, and this is in fact a ball of sludge. We call this tumor factive sludge because it sort of looks like a mass or a tumor, but if you move the patient, this will move around the gallbladder and it doesn't have any blood flow in it. And if I keep playing this video, you'll see that at the neck of the gallbladder there is actually right here a hyperechoic stone with a nice dense black shadow behind it. So this is the stone that you don't want to miss. Often we get distracted by seeing stones up here in the gallbladder, which, yep, it's good to know about them, they're there. You may see sludge, but this one is the stone you don't want to miss. This is the one causing all the problems, and this patient will need to have their gallbladder out pretty quickly, I imagine. Another example of the same. So once again, we have a pus-filled gallbladder. So this gallbladder is completely full of pus and has a distended gallbladder. So this is over 4 to 5 centimeters in diameter. And then there's the gallstone sitting down there in the neck with a nice shadow behind it. In case you didn't see it before, there's the gallstone sitting there down in the neck. And that can be really hard to pick because when that bile gets really inflamed and full of pus, it's not black anymore. It turns into this grey, almost liver texture. So it can be hard to pick. So just be aware that it isn't always black. And there's the sludge and pus. There may even be a little perforation there in the anterior wall. I'm not sure. Now, cholecystitis is the diagnosis that we're keen to make in the emergency department. This one needs admission, obviously, and needs to be sorted out with antibiotics and potentially surgery. What do we look for to define cholecystitis? Well, first of all, looking for that distended gallbladder. It's usually quite big, particularly if it's obstructed by a stone in the neck. You don't always see that stone. It may be further on down. We're looking for pericholecystic fluid. So that's fluid that usually builds up outside the wall of the gallbladder, in between the gallbladder and the liver. And it can just be a little rim, we can get little pockets of it, or we can get a little complex collection of fluid around the whole gallbladder as well. We're looking for thickening of the gallbladder wall, so we're looking to measure the thickness, and if it's over 3 millimeters, that suggests some inflammation or edema of the wall. You can put the color flow Doppler on and see if it's inflamed. Is there hyperemia or increased vascularity of the wall? But probably the most important sign for point of care clinicians is that sonographic Murphy's sign. So we try and bounce the probe over the true fundus of the gallbladder, and if it's there, it's tender, the patient will let you know straight away. So documenting a sonographic Murphy's is very useful. Bile can take on all sorts of unusual appearances. Sometimes you have bile, sometimes blood, pus, all sorts of things can build up in the gallbladder, and it can layer out. So it can even look like this. And I mentioned before about gas in the gallbladder. Here's a good example of that. So here's a gallbladder that looks a bit angry. There's some pericholecystic fluid there in the anterior wall, some sludge in the back here. But this bright white with a shadow behind it, bright white artifact here, is gas. And this is sitting closest to the probe. So this is gas that's floated up to the top of the gallbladder. Usually we would expect if there was shadowing behind a stone, it would be coming from the stone and going deep to that. So this is an example of dirty gas shadowing. It's not that nice hard black shadowing that we saw before behind the stones. This is dirty gas shadowing. Give you another example here. Here's an angry looking gallbladder that's got bubbles of gas floating up in it. Once again, a really thickened wall, lots of pericholecystic fluid in this one, and maybe even a little bit of gas outside there. So this is an example of Emphysematous cholecystitis, usually due to some sort of nasty gas forming organism. All right, let's talk about identifying the common bile duct, because this can be really tricky and can make or break it, particularly if we have biochemistry that suggests there's an obstruction. So the common bile duct's usually, in most normal sized adults, 3 or 4 millimeters in diameter, though it gets bigger as you get older. So the rule of thumb is once you get over 60, you can have a 6 millimeter gallbladder, 80, you can have an 8 millimeter gallbladder, and so on. If you've had a previous operation or sphincterotomy or a cholecystectomy, often it's up more around the 8, 9, 10 millimeter mark, and that's probably normal for that patient. The two main places we look for the common bile duct, if we can't see it clearly in its full length, which is often the case, we look in the head of the pancreas. So if you look in this bottom left-hand image here, you can see this is the left lobe of the liver, there's the head of the pancreas, and you can see the portal vein, or the portal confluence, which is that dark teardrop-shaped vessel there on the screen. And then in the head of the pancreas, there's two round structures usually. There's usually the gastroduodenal artery, which is the one at the 10 o'clock position in the head of the pancreas, and then the common bile duct's usually more around the sort of 7 or 8 o'clock position, and that's the one that's been measured on this picture here. You can put colour flow on to show that one's got arterial flow on it and one doesn't, and that tells you which one's the bile duct. So that's one trip there. If you can find it, you can try and turn long on it and get this picture over here, which is the one in the bottom right, where we can see the bile duct extending along in front of the red portal vein. The portal vein is traditionally red because the blood's flowing towards the liver, and usually the common bile duct is sitting just on the anterior side of the portal vein in parallel. Not always though. And then once again, if you follow the portal vein up or follow the gallbladder down, they point towards the porta hepatis, where it just enters the liver. And once again, if you get this in transverse, there's 3 structures there. There's on this screen on the top right here, we've got the red flashing hyperhepatic artery, which will be beating at you. The big blue vessel there is the inferior vena cava, and the portal vein is the dark vessel in the middle. So the common bile duct is the other ear of Mickey Mouse, or the other tube there, which is just near the neck of the gallbladder. So that'll be the common bile duct there. Colour flow can really help you if you're a bit confused about which is which. Alright, so here's a couple of examples. This is a longitudinal look through the common bile duct, and this common bile duct is massive. So this common bile duct is probably around 2 centimeters in diameter, and we can see a nice hyperechoic stone with a shadow sitting just here at the distal end of the common bile duct. So if the common bile duct is that big, there's almost definitely something going on, whether it's a stone or a tumour or something distally obstructing, and particularly if it's anything bigger than the adjacent portal vein, makes me think that, yep, there's definitely something going on there. To the really clever ones out there, if you look up here in the front of the liver here, you can actually see 2 tubes. So one of these will actually be the intrahepatic part of the portal vein, so that branch of the portal vein, and the other one will be a bile duct within the liver. Normally you can't see those little bile ducts in the liver, so if they get distended, they blow up and they're about the same size as the branches of the portal vein. So if you can see this double barrel shotgun sign, or some people call it the staghorn sign within the liver, that's a clue that there's some obstruction to the biliary tree. Now, cholecystolithiasis can be really tricky, and I think for point of care clinicians, trying to find the common bile duct is reasonable. Trying to find a measurement is reasonable. We once again measure it from inner wall to inner wall, but finding an actual stone in the common bile duct can be very hard. It's a difficult organ to trace all the way down, particularly as it hooks around the back of the duodenum into the pancreas, which is where most of the actual stones that are causing problem will end up lodging. So it can be really hard to see. So we usually use indirect measurement by looking at that. However, if you do see a stone, this is what they look like. So there's something that's bright and shadowing within the common bile duct. And we know that even for relatively experienced sonographers, it's not that great for picking up. So this is really an MRCP or an ERCP diagnosis. However, you're a doctor, so you've got biochemistry on your side. Use your brain. If the patient has obstructed looking liver function tests with a high bilirubin or jaundice, the lipase is high, just think there's something going on there. So don't settle for an incomplete picture of the CBD in that setting. You need to get a formal image either through the MIT or possibly with an ERCP or MRCP if it's appropriate. In many rural areas when they have CT, which can be good for looking at the common bile duct, but once again can't really rule out stones because these are almost always radiolucent. This is a time-sensitive problem though if you have a stone down there, so this is not one you want to spend too much time thinking about with an ultrasound if the biochemistry is telling you something bad is going on. Show you another few examples. We've seen this one already, and just to illustrate that, there's a gallbladder that is full of sludge and a small stone up in the fundus, but that critical one that you don't want to miss is that stone down in the neck of the gallbladder. Of course, not always stones in the gallbladder. We do see other things from time to time. So this is an unusual appearance with something that looks like sludge in the gallbladder itself, but you can see it's not actually falling to the bottom of the gallbladder, it's sort of wrapping all the way around. So this is a tumour within the gallbladder, most likely a cholangiocarcinoma. And that's what it looks like there. Another clue is you put colour flow on, and sludge should not have any flow in it, whereas this one clearly has flow. Just about spaced repetition, once again, here's a gallbladder there's a stone in the neck of the gallbladder. And as we track up towards the fundus of the gallbladder, you can see that the wall is really broken down. It's really hard to work out exactly where the wall is. So this is a patient with cholecystitis that probably has signs of a rupture going on there with some fluid outside the lumen of the gallbladder. Now, this is something I really want to drill home in this course, is that we often get excited when we're doing point of care ultrasound when we find something and we stop looking. So if you have this picture, you've got a 40-year-old woman that's overweight and has been recently pregnant, normal biochemistry that presents with epigastric pain, and you look and you see this in the gallbladder. So there's a whole heap of little stones sitting there on the posterior wall of the gallbladder that don't really look like they're going to be causing too much trouble in that position. If you roll this patient onto the left, they'll probably fall down into the fundus. You do want to have a good interrogation of the neck to make sure there's not another stone sitting up there in the neck of the gallbladder. But this could be a completely incidental finding in this patient. And so you need to use your brain, use your sonographic Murphy's sign, and try and work out, is this actually the cause of this patient's problem, or is this just an incidental finding? Because what we don't want you to do is find incidental gallstones, blame all of the patient's problems upon that, and stop looking for other more sinister causes, things like infections or gastritis or other abdominal emergencies, which we could be missing as a result of gallstone distraction. And lastly, not always do we see stones in cholecystitis. So particularly in older patients who are vasculopaths or diabetic patients, they can present very unwell with this appearance. And this is a picture of acalculous cholecystitis, so a big distended gallbladder that is tender to push on and has a thickened wall and makes you think that this is cholecystitis, but you don't actually find a stone. And the reason for this is that this is essentially an ischemic injury to the gallbladder. So the patient's unwell for other reasons. They developed sepsis or ischemia, and this is what happens to their gallbladder. So this is an ischemic or gangrenous looking gallbladder as a result of acalculous cholecystitis. And I just want to mention this one as well. So not all gallbladder wall thickening is due to gallstones or cholecystitis. So this is a patient that has clearly got ascites, so there's lots of free fluid around a somewhat abnormal looking liver. And you can see that gallbladder wall is really thick. It's 9 millimeters, and it looks all edematous, and you can see the striation within the wall. And think of the gallbladder as the eyelids of the abdomen. So anything that puts the venous pressure up, swelling and edema, or causes inflammation locally, basically causes the gallbladder wall to thicken up. Now, it may be due to cholecystitis, but in this case, where you've got a patient that's clearly got probably portal hypertension with a cirrhotic-looking liver and ascites, that fluid in the gallbladder wall is probably purely the result of that process rather than an actual primary gallbladder problem. We also see that picture in patients with heart failure, and also patients just with things like bad pancreatitis can get this as well. We are looking through the liver. We're not teaching you specifically about how to do a liver scan because that's quite complicated. But if you do see things in the liver, such as this is metastatic disease within the liver, lots of small islands of inflamed looking tissue with a hyperechoic halo around it. These are almost certainly metastases. And if you see things like this, for example, if you see something, you might be an abscess in the liver or a clearly abnormal looking area of liver, there are a lot of traps for young players and a lot of subtle things that can go on in the liver, and it's really hard to sort this out on ultrasound. So these are patients who you should be referring for formal imaging. Take-home points. Gallbladder is all about dynamic scanning, so ask the patient to hold their breath. Take a deep inspiration as long as possible to get a good window to see the gallbladder. Look through the ribs as well. Roll the patient if you're not sure what you're seeing, or if you need to get a better view, or you want to see what's going on with those stones. Remember, always look at the whole organ. We'll say this again and again. Look from the top to the bottom, from the left to the right, front to back, fan through so you're looking at the whole thing. And in gallbladders, it's all about getting a good view of the neck. Don't miss that culprit stone down on the neck of the gallbladder. Correlate always with the clinical and the biochemical picture. Work out if the biochemistry is suggesting obstruction, then you need to find that obstruction. If the clinical picture doesn't sound like gallbladder symptoms and you see gallstones, they're probably just innocent bystanders, and you need to integrate that into your decision making. And just be aware of all those pitfalls and false positives that we mentioned at the start. There's lots of things that can look abnormal in gallbladders. If not sure, get a formal scan. Is this an innocent stone? That's a doctor decision. And don't get distracted by those bright shiny stones when there's something else going on with your patient. All right, see you later.